Runners, are you dealing with side of the knee pain known as patellofemoral pain syndrome? Today we're going to be going over relevant anatomy. We'll go over some causes on what may cause this to show up in the first place. I'm going to go through a full exam, my exam for patellofemoral pain syndrome, and then I'll show you some of my favorite exercises for it. So first, let's go over the relevant anatomy. I have a handy knee model here. This is actually a right knee. So in patellofemoral pain syndrome, we're talking about the patella, which is the kneecap, and then patellofemoral, that's your femur, your main thigh bone. So if we turn this around, main thigh bone here. And then pain syndrome, but our third bone that's relevant here is our tibia. So that's your main big shin bone that you can feel when you run your fingers down your shin here. Once we get past these layers of quad tendons, we get the kneecap, and it actually lies right on top of the femur. I'll try and pull this back a little bit for you. If you can see in here, there's actually a little groove in the middle, followed by two walls on the side. Your patella sits in that groove, ideally, and it tracks right in the middle of it as you flex your knee and as you extend your knee. In people with patellofemoral pain syndrome, again looking at this groove in here, you notice the two walls on each side that go on the sides of that groove. People with PFPS, often their patella actually moves to one side or the other and rubs up on those walls when you do flexion and extension of the knee. If you rub up on those walls enough, eventually you're going to get inflammation in that area and it can cause pain. Now, what makes this happen? According to this great study from 2016, increased peak hip adduction is a risk factor for patellofemoral pain development in female runners. Now, when they say hip adduction, this is what that looks like. It's the leg going towards the midline of your body. What this means is that areas around the knee, such as the hip, the core, the ankle, and the foot, are huge players in PFP. That means it's not all about your quad. In fact, your quad isn't very involved with hip adduction. It's more about your hip and your core function, and when you're standing, it's more about your ankle and your foot as well. Another study looked at runners specifically. It showed that in stance phase, female runners with patellofemoral pain have increased hip adduction, as we mentioned earlier, and male runners have increased hip adduction as well, and contralateral pelvic drop. So going back to the model here, we can see adduction looks something like this. And adduction is always coupled with internal rotation of the femur. So those two movements go together always. Again, adduction, internal rotation of the femur. And now look at that little space. If we add a little bit of knee bend here, all of a sudden that space goes completely away. And that's where we get the friction and the pain in patellofemoral pain syndrome. Now, what about the quads? Yes, the quads are in the area of pain. That's where those tendons come down. But I found that often the importance of the quads is really overblown because when your knee hurts, you don't use your quads very much because your knee hurts. So often they're weak, but not super involved with the actual pain syndrome. So starting with the exam here, go ahead and just take a visual look. There shouldn't be any huge swelling. So if you have enough swelling that you can't see your kneecap anymore, this is probably not PFPS, this is something else. So roll up so you can see the bottom of your quad too. And you can do a quick little swipe test and see if anything that looks kind of like jelly comes up towards the bottom of the quad. Here on Sebastian, we don't have that, so we'll move forward. We're going to poke around the outside of the kneecap. So you're going to poke all the way around the circumference and fairly hard. And if there's any pain there, we may be talking about a different condition, something like jumper's knee. As you come to the bottom of the patella, I want you to push down on the patellar tendon all the way to where it attaches to the tibia at the tibial tubercle here. Any pain along there, we're probably talking more about patellar tendinopathy, or if it's just at the point of the knee and you're a teenager, that's more like Osgood-Schlatter or a bone defect there. Next, we have a grind test. So in people with PFPS, this is usually fairly painful. We'll start in the leg neutral position like this. Put your hand on top of the patella and then push down and grind around here. You'll feel the little groove and you'll feel the walls on the side of the groove. And usually when you push to the outside and push down and move the kneecap around in that area, that hurts. It's usually painful on the outside of the kneecap. Then we're going to move on to some stress tests of the ligaments. So number one, we're just going to let the knee fall here. Any problems here, Sebastian? No? Good. So if you can't get terminal knee extension, so knee all the way straight, we may be talking about a meniscal injury instead of PFPS. And if you can't get the knee all the way bent, let's see if we got it today. And he does. We may also be talking about a meniscus injury in a different area. Now we're going to do some stress tests of the ligaments. So we're going to hold the bottom of the foot here and then let the knee straighten out. And if there's any laxity or pain, laxity meaning it feels like jelly, and pain, obviously, if there's pain in the middle of the knee, that would be positive. In that test, we're testing mostly the lateral collateral ligament here. And then for the inside of the knee ligaments, I'll show you guys on the other knee. Similar test. We start with the knee bent, and then we push the knee towards the midline of the body and let the knee straighten. No pain there, right? So pain or laxity in that would imply more of a ligamentous injury, probably to the MCL of the knee, not PFPS. So these tests are all passive, which means that the person being tested is not doing anything. But for patellofemoral pain syndrome, usually this comes on with active motions. So contracting the quad here, that's active. Things like squats or running or hiking, that's all active. That's much more common to have pain. So if none of these are painful, don't freak out. This may still mean that you have PFPS, and especially if that compression, which is an active external force that mimics active exercise, causes pain, we still may be in this boat. Orthotic treatment can help for some people, but it's way easier to just strengthen the arch. Rehab usually starts with doing 3 exercises 2 times a week. The 3 exercises usually fall into the following categories. We got 1 for the hamstring, 1 for the glute/core, those tend to go together, and then 1 for the quad. We're going to start with a quad isometric exercise because it's easy to find a position like this that feels okay. If you are having issues with putting your knee on the ground here, best to get something squishy under it. And if you're having issues with the depth, you can stack some books and put something squishy on top of that, and then hold this position. From here, we're going to lean into the outside of the foot. Keep all your toes on the ground, but focus towards the outside of your foot. And then I want you to pretend like the floor is soft and you're going to make a huge dent in the ground with your foot. So I'm actually not moving. I'm not going all the way up, but I'm about to start going up by shoving my foot into the ground. If you shove it hard enough, you're going to get a great burn in the quads, and that's what we're looking for here. Now to show you again from the front, the one big fault that I see commonly is that people will start loading and their knee will collapse in. And like I said before, this is hip adduction. We don't want this. This actually contributes to the pain in your knee. So make sure that when you load into it, you're targeting towards about the pinky toe, or at least getting your knee towards the outside of your foot. Again, keeping all your toes on the ground, and then shoving your foot through the ground. Next is our hamstring exercise. So I'm using a couple of furniture sliders here. If you have hard floor, you can use something soft like a washcloth. But furniture sliders are pretty cheap. They're at most of your home goods stores. Slip them under both heels here, and then perform a bridge. And you're going to slowly move your heels away from your body. If you can get straight, that's even better. And then back. The slower you go, the faster it will burn. And your goal is to keep your butt off the ground as long as possible, or get to a hamstring cramp. That works too. Last one is our glute/core exercise. We're going to kill 2 birds with 1 stone here. Start on top of a bench in about this position, and then drop your butt all the way down. And you're going to choose one leg to start with. Pick up your other leg. This is the core component as you stabilize here. And make sure that your hip does not drop. So if you had a glass of water right on top of your stomach, it should not spill over the side. From here, you're going to drop your butt and come all the way back up and down. Again, the slower you do this, the faster you'll get the burn in your glute. And making sure that that hypothetical glass of water on your stomach is not tipping off to the side at any point. If you want some help with this, our contact's below. We see people virtually and in person in Southern California.